next keynote address. And the next topic is on preterm birth, screening, prevention, and evidence-based interventions by Dr. Stephen O Brien. Requesting Dr. Stephen O Brien to kindly render the keynote address. Doctor is a consultant obstetrician with an interest in fetal medicine from North Bristol NHS Trust. He's a national lead in operative birth training and also the lead clinician at Southwest Complex Termination of Pregnancy Network. Over to you, Doctor.
Marvellous. Thank you very much. I feel a little bit wary following my two distinguished colleagues. The first one spoke about very advanced genetic IVF, and the second one has just talked about AI and fetal medicine. This is much less exciting and much more basic, and it involves lots more pictures of forest plots from Cochrane reviews, so please bear with me. I hope you like data. So preterm birth, the first thing is obviously it's very, very important. It's still the leading cause of death worldwide for children under the age of 5, with 49% of all those deaths being related to preterm birth. And really, you should be up here and not me. The rate of preterm birth and the burden of disease is significantly higher in India than it is in the UK. So I'm sure you've seen a great deal more of it than I have on an individual basis. It's important to recognise that although the death rates are high early on, they are getting better and better and better. And sometimes, particularly in larger centres, this leads to our neonatal colleagues being very hopeful and very optimistic that if a baby is born alive, long term it should be fine, or words to that effect. And whilst babies can survive, we do want them to stay in for as long as possible. This, for example, this is the patient leaflet that gets given to all women who are having an extreme preterm birth in the UK if their baby's going to be born at less than 26 weeks. And we now offer resuscitation down to 22, sometimes 21 if you're being particularly sporting. And our neonatologists show this picture with the very positive green colours showing babies that survive. The important thing is to read the small print down the bottom, which is of those babies that survive, a quarter survive without severe disability, but this includes mild cerebral palsy and intellectual disability. So the question becomes, do we think that's mild disability? I'm not sure as parents, if any of you have children, you would think so. I know I certainly wouldn't. Your risk of long-term learning disability, assuming you survive, clearly gets better in time, but it does start off as very, very high. This is probably the best data we've got. It's from an enormous retrospective Scottish cohort study, and it's looking at your chance of having a special needs statement age 5 by the number of weeks at which you're born. It's a logarithmic scale, so you'll have to expand it in your mind, but as you can see, even babies born at the kind of the magic 30 weeks, the neonatologists always say if the weeks start with a 3, then they're basically fine. Even at 30 weeks, there's still a 1 in 6 to 1 in 7 chance of this child having special needs as it gets older. That then has consequences both for the children, the parents, and for society. This is one of my favourite slides. That man up on the top right is Robert McNamara. He was the US Secretary of Defense in the early stages of the Vietnam War. During the Vietnam War, the Americans were really struggling for manpower. They had the draft, but you were excluded from the draft if you were judged to be intellectually disabled, if your IQ was less than 80. When the Vietnam War escalated, the United States decided that they needed more manpower, and they reduced that IQ threshold from 80 down to 70 in 1968, just before their big troop surge in 68-69. It was a disaster. They recruited an extra 350,000 soldiers, but unfortunately, because of their intellectual disability, it was actually harmful to the ability of the US Army to try and carry out combat operations. Even in the most man-starved army, in the middle of its biggest troop deployment in the space of the last 80 years, they could not find something for these people to do that was not actively harmful to the force as a whole. So whilst we can get babies to survive at early gestations, and that's good, we need to be mindful that even if they're born alive, they will have higher rates of intellectual disability later on down the line, and that is not a small thing, either for them, their parents, or for society. So, in light of that, we've been trying to prevent women having early babies for essentially as long as there's been obstetrics. There is a very long list of things that we know don't work. I apologise if any of these are your particular favourites. Cochrane says they don't make any difference. It's from bed rest, prophylactic antibiotics, all the way down to the supplementation of calcium, vitamin C, vitamin E, and zinc. And I'm sure everything else has been tried as well. Things that might work. So, as I'm sure you know, there's emerging evidence that routine cervical length screening, even in a low-risk population, may have some beneficial effect if it's undertaken at less than 24 weeks, traditionally at the mid-trimester anomaly scan. There's lots of different studies. The biggest one we've got is probably French data, which is the top paper, and it showed a reduction from about 5.6% of all births at under 34 weeks down to 5.4%. That difference isn't huge, but it is there. That still needs to be ironed out. That was a retrospective study as part of a wider study looking at how ultrasound was used in pregnancy, and so we need prospective national scale data. Work to do that is underway at the moment at the University of Birmingham in the UK, led by my colleague Ari Kumarasamy. Progesterone, we've got reasonable data that progesterone works. It seems to work in two cohorts of women. Those are women who've had a previous preterm birth, top forest plot, and women with a short cervix. So by short cervix, less than 25 millimeters. It may have an effect, but we don't have the data yet to say at a robust level that it has an impact for either people with multiple pregnancies or for women who have a identified short cervix of between 15 and 25 millimeters who are otherwise opportunistically very, very well. The other thing that we know works is cervical cerclage. Is likely to be of benefit if you find a cervix of less than 25 millimeters. There are a few caveats with cervical cerclage. It's a common operation. Many of us undertake it. It has varying levels of effect. If the membranes are exposed, if it's a rescue cerclage, then the mean additional time in gestational weeks gained is 5 weeks. Clearly that's a mean. There's a range. For some women it might be a couple of days. For some women you might actively make it worse, and in other women you'll get them all the way to 37 weeks and they'll give you a bottle of whiskey at the end of their pregnancy. The problem is that 5 weeks can be good, it can be bad. If you're at 21 weeks, actually, you're likely to get this baby to a stage where it could survive and hopefully do reasonably well. If, however, you've got exposed membranes at 17 weeks, adding 5 weeks onto that, 22 weeks, while in some ways better, in some ways is also very much not better in terms of what this is going to mean for this woman and her emotional and physical journey. So you can, of course, do it. You just need to carefully caveat what it is you're then engendering for the rest of the pregnancy. There's lots of other questions with cervical cerclage. So do you use monofilament? Do you use tape? And how do you do it? The best data we've got is from the C-Switch trial that I'm sure some of you will know. That showed that there's no difference between either Mercilin tape, which was the older fashioned stuff, or monofilaments, predominantly Ethicon 1.0 tends to be most popular in the UK. I'm sure there's lots of ones here as well. In terms of how you do it, the trick is, as always, try and do it as high as possible. There was a lovely paper that came out 2 years ago by Graham Tideman, who's an obstetrician in Fife in rural Scotland. And he got a series of cervical stitch trainers and gave them to 28 self-appointed experts around the UK and internationally, and got them to put in a cervical suture into this silicone cervical stitch trainer model and send it back to him. And he then CT'd them and measured how high they managed to get with their suture. We know that we get best effects if the suture is placed more than 10 millimeters above the external os. Only about 2/3 of self-appointed experts manage to do that. So we want to get it as high as possible, and our ability to do that isn't as good as we think it is. One of the things that did come out of that study is those people who used monofilaments. So with Mercilin tape, there can sometimes be a very big needle. If you use a monofilament with a smaller needle, it may be easier to get it higher up just purely because of space. Then it's a question of what kind of stitch do you use. McDonald's is clearly the most common. It's got some benefits in terms of it's easiest to take out. There may well be a benefit to doing a Shirodka. The relative risk of preterm birth at less than 34 weeks is about 0.9. It's got some downsides, harder to get in, more analgesia, and clearly much harder to take out. And there's emerging data from Andy Shannon's group in Tommy's that abdominal sutures are likely to be better again, even for women who've not previously had a preterm birth. Clearly, the big downside with abdominal sutures is it's an abdominal operation. You can do it laparoscopically, of course, if she's less than 14 weeks gestation. The bigger thing is we can never take this out. This woman needs to have cesarean sections for the rest of her reproductive career. And at the moment, we're doing anomaly scans at 20 weeks. If you find a significant structural anomaly at 20 weeks, the woman's options are then much more limited. If she needs to end a pregnancy, we're then exposing her to a hysterotomy and all the unpleasantness that that involves, both for her and also for future pregnancies. So abdominal sutures probably do work the best at preventing preterm birth and cervical failure, but they come with significant consequences. Management. I'm hoping that everyone knows this backwards, and this is the very basics. And if it is, I do apologise, but I thought I'd do it again. Magnesium sulfate, it is useful. It is not a wonder drug. When it first started coming out, when there was a retrospective analysis of the MAGPIE study back in the late 1990s, we all thought, oh, this is fantastic. It turns off cerebral palsy. It probably doesn't work as well as we had hoped. It probably reduces your rate of cerebral palsy up to 2 years old, but doesn't have an effect on long-term disability or death. In terms of the significance of the cerebral palsy, that's not a bad thing, but the thing we have to remember is cerebral palsy isn't a yes-no test. It's not like sending an amniocentesis sample off to the lab and they say there are 3 copies of chromosome 21. Instead, it's a holistic assessment by a paediatrician, sometimes using some scores as well to say, does this baby have a pattern of movement that fits in with a diagnosis that's called cerebral palsy? If you look at the sub-analyses of what these children can do in terms of their developmental tests, so their balance scores, probably the best way of assessing what children can do in terms of their cognition, their motor skills, and their reading and writing, there's no difference between the babies that were exposed to magnesium sulfate and were born preterm and those that were not. So it may have an effect, but it doesn't change the long-term, what kind of child do you end up with in terms of what sort of school will it go to, will it be able to read, will it be able to write, will it be able to go to university, will it be able to have a partner, work, all the big things that we worry about as parents. The other thing is that the effect is gestation dependent, and again, as I'm sure you will know, the number needed to treat goes down into the less than 10, theoretically, if you're less than 24 weeks, but as soon as you cross 30 weeks, it's about 1 in 64. So the NNT does go down fairly rapidly. It likely has no effect over 32 weeks, and that's reflected in the various international guidelines. These are just the forest plots for those of you who are excited by that sort of thing. It probably does reduce the risk of cerebral palsy at age 2. It doesn't have an effect on your risk of death, and it doesn't have an effect on your risk of a major neurodevelopmental delay or learning disability by the time the children go to school. Steroids, again, extremely basic, I'm sure. We know that steroids reduce your risk of neonatal death, and that's what they're designed for if they're given at less than 34 weeks. That comes with lots and lots of caveats. So the first thing is the thing we've all been noticing over the last 5 or 10 years in the literature, which is that steroids in babies that are not born preterm and go on to be born late preterm or at term do probably increase the long-term risk of neurodevelopmental or behavioural difficulties. There's lots of different studies. You can take your pick. There's excellent Norwegian data. There's quite good American data. Your relative risk of any kind of behavioural abnormality diagnosis probably goes up by a factor of 50%. So relative risk of about 1.46. There are a number of systematic reviews and meta-analyses going on. They all have their issues because for this sort of thing, you really want to have good homogeneity in terms of what counts as a neurodevelopmental disability, what gets classed as autism in middle-class New York versus what gets classed as autism in rural Russia are very different things, and the amount of heterogeneity in the follow-up data is so big that it makes that sort of individual patient data meta-analysis very challenging indeed. But it probably has an effect. So the days of giving steroids to everyone and saying, have it on the off chance you have your baby early, those should be behind us. It was slightly before my time, but when I was learning my fetal medicine, my old professor had run a twins clinic in Bristol who was called Peter Suttill. He had the practice of every 2 weeks from 24 weeks giving all women with twins in Bristol a course of steroids on the basis that they might deliver in that next 2 weeks, and this way they'll be protected from the risk of preterm birth. He noticed this was a problem when babies are born, they routinely have their head circumference measured. The head circumference of his twins who were born after about 6 to 8 courses of steroids had HCs of about 3 standard deviations less than the national average. It definitely does cause brain shrinking, and it's not a benign intervention. So we know that we do want to give steroids. We're just going to be careful. When do we give them? Timing of birth is always the question. Again, it used to be thought that there was no effect until it had been 48 hours after the first dose and the effect wore off after 10 days. It's probably more like it starts to have an effect after 2 to 3 hours, and you start to lose effect by the time you hit 3 to 4 weeks. There's lots of variability within that, but that's likely where we are. There isn't a role for shortening the course in terms of giving them 12 hours apart. You may as well stick to 24 because that's what's in all the papers, so we may as well do what we have the literature for. And as one of my esteemed colleagues said earlier, earlier, infection is not a contraindication to giving steroids. Clearly, if the woman's got chorioamnionitis, you don't delay delivery, but if you know it's going to be a few hours until the baby's delivered anyway, there's absolutely no harm in giving her steroids, and you certainly will not make the sepsis any worse. Delayed cord clamping, this is the kind of new and jazzy thing. We know that delayed cord clamping increases the neonatal hemoglobin levels. It seems to reduce your risk of death if you do it as part of a preterm birth. There are, however, some caveats with it. So the first is that, again, it's gestation dependent, and the second is that it's physiologically dependent. So gestation-wise, the effect is much greater for the earlier gestations, 22, 23, 24, 25, 26 weeks. There's very likely to be no effect once you're over about 34 weeks. The other thing is it's physiologically dependent. So in order for it to work, the baby needs to open its lungs, reduce its after pressure, and then enable the blood from the cord to flow into the baby. So we have occasionally had times when one of our more junior doctors has been delivering a baby. They've left it there for a few minutes hoping the delayed cord clamping is going to work, but the baby's not breathing. Under those circumstances, nothing's happening. The baby's just not breathing. It's not getting any more blood. It's getting less oxygen. So if the baby's crying and making chest movements, fantastic. You'll be increasing its hemoglobin levels. But if it hasn't yet opened its lungs, it's not closed its duct, it's not going to be increasing its hemoglobin levels, and you should cut and run. Mode of birth, again, this is a slightly controversial one. The theoretical standpoint from Cochrane and from NICE in the UK at least, and from the ACOG, is that there's not enough evidence to recommend one form of mode of delivery for planned preterm birth of one over the other. However, there's quite a lot of anecdotal data one way or the other. So we're fairly confident that with a caesarean section, if the baby's less than 27 weeks, you probably get a lower risk of intraventricular hemorrhage. We know that intraventricular hemorrhage in and of itself isn't a good thing, but what we can see from the steroid data was that, from magnesium sulfate data, was that although magnesium sulfate gives you lower rates of IVH, it doesn't track to your long-term risk of neurodevelopmental delay age 5. So whilst lower IVH rates, if you're delivering a baby via caesarean section less than 27 weeks is probably a good thing, we can't be confident and say this definitely means that your baby is going to be better off for the rest of its life. That hopefully should be answered with a big study that has just been funded by the NHR in the UK, run by my colleague called David Dodd in Cardiff, trying to randomise women to either vaginal birth or caesarean section for less than 27 weeks. Again, the only thing to hold in your mind against that is the anecdotal thing that I'm sure we've all picked up, which is in women who've had a classical caesarean section, so really the sub-25, 26 weekers, they do seem to have higher rates of miscarriage, particularly placenta accreta and stillbirth. And we need to weigh the two. So where are we in terms of preterm birth? Preterm birth is still a bad thing. It's still worldwide the leading cause of neonatal morbidity up until the age of 5. There's probably only a few things we've got that can prevent preterm birth in the first place. And that's cervical length screening via a transvaginal ultrasound in trained hands prior to 24 weeks, so ideally at your mid-trimester anomaly scan, and some kind of treatment if the cervix is less than 25 millimeters. In an ideal world, you would want all women to have access to both progesterone and cervical sutures, but one or the other. If you are doing a suture, you can use whichever thing you would like to use, but do it as high as you possibly can, and I probably wouldn't do an abdominal suture in a first pregnancy. If preterm birth happens, either it's just happening on its own or it's indicated for another reason, there's a few things that we know work, which is give one course of steroids, ideally timed to be around about 48 hours prior to the baby being born, but even a few hours will help. It's not going to have much effect after 3 to 4 weeks. Give some magnesium, but don't worry too much if she's over 32 weeks. Do delayed cord clamping, but only if the baby is breathing and crying. CPAP does count. So if you can get your neonatologist to scrub in, as we all should with our good multidisciplinary teams, and they can do bedside CPAP while the baby's still attached to the cord, so much the better. That will open up the lungs and enable that cord clamping to be useful. But be wary of other interventions. There's lots of other things out there that we do not yet, as far as I'm aware, have the evidence to say that they result in predictably better maternal and neonatal outcomes, and carefully consider the mode of birth based on the gestational age and future reproductive plans. I would say that if you're doing a caesarean section at less than 24 weeks in a woman who is likely to be able to have future pregnancies, that might be tricky to justify, but clearly not in all cases. Fab. I've rattled through. That's it.